going here. So thanks everybody for joining us today. We have another special guest. Today we're welcoming Dr. Michael Brener, who goes by Mickey, to talk to us about one of the many papers it looks like that he's published recently that I've seen at least come across my inbox. He's currently a general cardiology fellow at Columbia University, New York Presbyterian, New York City. And as we were just talking, he's going to be pursuing advanced training at the end of this year. Fortunately, it's not an advanced heart failure, but he's going to be doing an interventional structural fellowship, and will be remaining at Columbia for that. He went to medical school and did his internal medicine residency training at Johns Hopkins. And then he did a year as the assistant chief of service before beginning his fellowship training at Columbia. Dr. Brener's research focuses on right ventricular mechanics with broad applicability to a variety of cardiovascular disease states, including those supported with left ventricular assist devices. So the paper that I saw that Dr. Brener had published was in the Journal of Cardiac Failure back in September, which he's going to be talking to us about today. And you see the title there on the screen, but he's been very active, and I believe you've published a few other things kind of related to this since then, if what I can see. So yeah. Well, thanks so much for joining us, and we look forward to hearing from you. So take it away.
Perfect. Thank you, guys. Thank you, Dr. Beasley, and thanks for everybody joining in. We've talked a lot about this paper in a number of different fora, and usually it's some poor soul that has to explain this paper, which is very complicated. I'm glad that I just will do it, and hopefully it'll stimulate some interesting discussion at the end. Just so I know, do we have until 4 or 4:15? When should I?
I think probably 4 o'clock would be great, because I'm not sure. Yeah, I'm not sure what other people might have scheduled at 4 o'clock. So
that was a silly question. As it was coming out of my mouth, I was like, yeah, we should probably end by 4. So these are my disclosures. Again, please call me Mickey. Here's just a screenshot of the paper. We can probably send it around if it hasn't already been sent around. What we'll try to talk a little bit about is just sort of taking a 40,000-foot view and trying to understand the clinical problem here of right ventricular dysfunction in patients who are treated with LVADs. And then we'll talk a little bit about the methods for the paper. So a little bit about right ventricular pressure volume analysis. It's a mouthful and it's complicated, but I'll try to break it down so that we can at least start talking the same language as we review the study findings and try to sort of understand what we were able to uncover. I think before I dive in, I should mention that this paper was really intended just to stimulate discussion and to show that this method can be used and can generate clinically meaningful data. At the end of the day, it was 4 patients. It's a glorified case report, but nonetheless, I think it's an important first step. And as was alluded to, we're really trying to broaden this work and expand it to more and more patients so it can be part of the routine evaluation of patients with LVAD. So as many of you know, right ventricular failure, common, very morbid. We don't really fully understand why patients develop RV failure after LVAD implantation. But there are a lot of different sort of theories certainly out there. Oftentimes we invoke issues related to preload, afterload, contractility, lusitropia, and all the key determinants of ventricular performance. And oftentimes sort of interventricular interaction is sort of thrown in there as a potential pathologic culprit. But what really is interventricular interaction? And so the way that we have defined it, both in the paper and in a lot of the subsequent literature that we put out, is just really the influence of one ventricular's function and performance on the other. And oftentimes it's cited as a reason why patients with LVADs develop RV failure, because as you unload the left ventricle and you basically adjust some mechanics related to the septum and the force of left ventricular contractility, there is thought to be a consequent diminution in RV function, but that really has never been proven. And part of the reason why is because it's very challenging to measure right ventricular function, particularly in patients with LVADs, both non-invasively with echocardiography or even cross-sectional imaging, and challenging or at least cumbersome to do so invasively. And so that's why, and part of the reason why that is because the interventricular interaction, even as a concept, isn't just one thing. And this schematic that I put together sort of illustrates to you the different dimensions of interventricular interaction. I think it's probably easiest to conceptualize that there are serial interactions between the right and the left ventricle, meaning the function of the left ventricle, sort of interacts as part of one large circuit with the right ventricle. That's sort of easier to conceptualize, but there are other dimensions to interventricular interaction, like parallel interactions, as well as different interactions throughout the cardiac cycle. And this schematic sort of illustrates these different dimensions and what we were trying to do with some of the in silico modeling that was featured later on in the paper. But to take sort of a quick sort of view of sort of how we actually did the pressure volume studies in these LVAD patients, all of them were brought to the cath lab for a standard invasive hemodynamic ramp test. These ramp tests were basically pioneered by my mentor, Uriel, and he really established sort of the protocol that we were following. And during the ramp test, we had a dedicated echocardiographer who was performing 3D volume reconstructions of the right ventricle. And obviously we had the PV loop system. And this figure here in the bottom right sort of illustrates to you basically how the PV catheter works. It's a pigtail catheter. It has these sort of electrodes at the distal portion of the catheter that generate an electric field. And the voltage drop that's measured across the different electrodes that are spaced throughout the catheter generate these segmental pressure volume loops, which are what all these sort of red loops are. And then those loops are basically summated to take you from cross-sectional areas to volumes, and combined obviously with the pressure data to generate pressure volume loops, which we'll get into in just a second. And so the way that we use, or the way that I sort of explain pressure volume analysis, I tell people that it can sort of give us information in 4 key domains. So the first is obviously it can tell us about pressure and volume relationships in the ventricle. So each loop basically summarizes ventricular performance in one cardiac cycle. It's a major limitation of pressure volume analysis because we don't get the sense of, let's say, how the ventricle is performing, over the course of a minute or an hour. So, concepts like cardiac output aren't necessarily related particularly well on the pressure volume diagram. But anyway, the height of the loop basically represents peak systolic contraction in the ventricle. The width of the loop represents the stroke volume. And the loop itself can be sort of divided into 4 discrete phases. So you have the diastolic filling phase here in blue. You get the mitral valve opening. Can you guys see my cursor, by the way? I'm sorry. You can? Yeah. So
yeah, we can see it.
Perfect. So mitral valve opens here. You then, mitral valve closes. You get the onset of isovolumetric contraction. That's basically where there's a morphologic change in the ventricle that changes pressure within the ventricle, but none of the valves are opening. So you just have an increase in pressure. And that's followed by aortic valve opening and the ejection phase, aortic valve closure, and then the isovolumetric relaxation phase, followed by mitral valve opening. And so that's sort of the pressure volume loop, sort of in a nutshell in the right ventricle. Most of us are used to seeing pressure volume loops in the left ventricle, and there's some important differences between right ventricular pressure volume loops and left ventricular pressure volume loops. We can touch on that if we have time a little bit later, but it will sort of come up when we review the data from this paper. So I don't want to spend too much time on it right now. The other thing that pressure volume analysis is helpful for is that it quantifies systolic and diastolic properties. It really in a much more granular way than other modalities like echocardiography can. And so the systolic properties of the ventricle are captured by this line here in red, which is the end systolic pressure volume relationship. It basically connects 2 points. The first is V0. V0 is sort of what's considered the unstressed volume of the ventricle. So the amount of blood that you could put into the right ventricle before there would be an increase in pressure. Think of it as like the amount of fluid that you can put into a balloon without seeing it expand. And so the ESPVR, this end systolic pressure volume relationship, connects the V0 point and this point of peak elastance, sort of right at the end of the ejection phase. And the slope of this ESPVR is called end systolic elastance, and that is the widely used sort of surrogate of contractility, this load independent measure of ventricular systolic performance. And then you can see this line here in blue, which sort of hugs the filling phase of the right ventricular pressure volume loop. That's the end diastolic pressure volume relationship. It can be modeled with a number of different constants that summarize the relaxing properties of the ventricle. And in this paper, what we did is we sort of created an index. We created indices actually to standardize the comparison of systolic and diastolic function across patients. And so we, in order to summarize systolic performance, we used this index called the V20 index, which is basically the point at which the end systolic pressure volume relationship reached a height of 20 millimeters of mercury. And sort of similarly, or in the same vein, to describe diastolic function, we use this V10 index, which describes the point at which the end diastolic pressure volume relationship reaches 10 millimeters of mercury. And then we also use pressure volume analysis to understand the energetics of myocardial contraction. And so this diagram sort of illustrates some of the indices that we can measure from the pressure volume loop. So the stroke work, or the SW, that's the area captured within the pressure volume loop, and that's basically how hard the ventricle has to work to contract blood. When you combine that with the potential energy, which is the area outside of the loop, but bound by the end diastolic and end systolic pressure volume relationships, you can sum that to get the pressure volume area, or PVA. And PVA is important because it is directly and linearly related to myocardial oxygen consumption, which is a sort of important sort of barometer, I guess, or measurement of ventricular performance. And in this study, one of the parameters, again, that we use to understand sort of the energetics of the right ventricle in these VAD patients is the pressure volume area ISO at the V10 index. And what that does is it just provides a afterload independent assessment of ventricular function. So if you took away basically all the afterload, how well or how effective would the ventricular contraction be? And it basically measures the area that is captured within this area in blue here. So it's from the end systolic pressure volume relationship all the way through the end diastolic pressure volume relationship when it reaches the V10 index. There's obviously a lot more to talk about right ventricular pressure volume analysis, but just for the sake of time, I'll just refer you guys to this paper. It just came out, and it really summarizes sort of almost everything that we've learned over the last 2 years doing these complex right ventricular pressure volume studies. Just takes you through sort of the physiology, some of the theory behind some of the assessments that we're doing, and the clinical applications. And so I'll be happy to send that out to you all. It's not too dense, but it's a little bit more in depth than what we have time for right now. And so let's get to what we actually found in this study. So again, I sort of alluded to this. This manuscript was really a case report, really. We studied 4 patients who had LVADs. You can see that 3 of the patients, the first 3, were sort of your prototypical LVAD recipients, males, relatively elderly in their mid 60s, with very poor left ventricular function at baseline, some heterogeneity in terms of baseline RV function. Two of the subjects were undergoing these RAM tests as part of sort of routine monitoring, as part of the standard of care 1 year post LVAD implantation. One of the patients underwent the RAM test because he was having a lot of suction events, and they were having difficulty up titrating speed. And then the fourth subject, which was from one of our collaborators at Allegheny General, Manri Kanwar. This was a patient who was very young and had an acute myocarditis, and was bridged first with a VAD, and was getting the RAM test sort of to better understand her hemodynamics. They were having a lot of difficulty just titrating her medical therapy and figuring out the optimal LVAD speeds for her. And so she was brought in for an invasive RAM test. And this table is just, again, recapitulated from the paper, showing you the baseline hemodynamics for most of the patients. I'll draw your attention to subject 1, in that his pulmonary pressures were elevated, and you'll see when we get to the pressure volume loops why that's important. When we were doing these studies in real time, we didn't really appreciate that, but now that we've done many more studies, we realized sort of how important the baseline pulmonary pressures are and how they influence the shape of the pressure volume loop and the response to different LVAD speeds. And so this is sort of the money shot, I guess, from the paper, and I'll take you in depth through the individual patients. But suffice it to say that we basically identified 3 key patterns of changes in the pressure volume loop as a function of changing LVAD speed. And so the first pattern that you see, and this was from subject 1. This was the gentleman who had elevated pulmonary pressures. You see that as we increased the LVAD speed, there were really no significant changes in the shape or the contour of the PV loop. And contrast that with what you saw here, sort of one over to the right. This was the patient who was getting a lot of suction events, and you see that there are very significant changes in the pressure volume loop. We'll dissect some of those changes in just a second. And then the third pattern, what we've now sort of come to appreciate as sort of the normal or the sort of prototypical response to changing LVAD speed, which is really just a change in diastolic function. And so let's just drill down, zoom in a little bit on some of the individual pressure volume loops in individual subjects. So this was subject 1. As I mentioned, he had the pulmonary pressures, 40s over, I think, teens. And you can see here that the end-systolic pressure volume relationship really is not changed all that much across 800 RPM speed changes. While there is maybe a slight difference in the V20 index, by and large, the slope of the end-systolic pressure volume relationship is not too different between the different tested LVAD speeds. And similarly, the V10 index, which is again all the way down here, is really unchanged across the range of speeds. And there's no change in the width of the loop, the height of the loop, and as a result, stroke work doesn't really change across the LVAD, the range of LVAD speeds that we tested. And what we've sort of come to surmise, seeing this pattern a lot, is that perhaps these elevated pulmonary pressures basically train the ventricle. Patients have probably some degree of right ventricular hypertrophy, or at least some exposure to chronic pressure overload that makes them resistant to small changes in septal positioning, and perhaps small changes in loading conditions that occur with increased LVAD speed. And so that's sort of pattern number 1. The second pattern is a bit controversial. I think that now that we've done more studies, we're coming to sort of rethink this pattern. I think what you can clearly see is that there's a change in systolic function. So the loops in black represent sort of the lowest speed, in this case 5,000 RPM. And when we go to the blue loops, you can see that there's clearly a change in the slope of the end systolic pressure volume relationship. And another thing to take note is that pressure generation in the ventricle also declines. So the height of that loop has also declined. And so from this case, we thought that there were some clear systolic interactions, meaning that when you changed LVAD speed, you acutely altered systolic performance of the right ventricle. I think that the controversial part that I was alluding to is that in the initial sort of analysis, we used a software program that basically automatically calculated the point of diastole through which the end diastolic pressure volume relationship runs through. And we're not convinced that this is truly the end diastolic point in this black PV loop. And if you move it over to where I suspect it is, you see that there really aren't actually that many diastolic change. There's not much diastolic change. And we haven't actually observed this pattern in any of the subsequent patients that we've studied. I think it's more reasonable now, sort of in hindsight, to say that this patient really just had diastolic interaction. And it's something sort of that we're working through now that we have more patients. And then finally, the third pattern, and we'll see this in subjects 3 and 4, and this is what we're seeing very consistently in the subsequent studies we've performed, is this change in diastolic function only. And what we see is that as you increase LVAD speed, the V10 increases, meaning the volume at which the end diastolic pressure volume relationship reaches 10 millimeters of mercury, suggesting that actually the ventricle becomes more and more compliant as you increase LVAD speed. And note that this patient's pulmonary pressures were normal. And this is what we've seen in a lot of patients who have, quote unquote, echocardiographically more normal appearing right hearts post LVAD implantation. And this is what you see from the final patient. Again, just this change in diastolic function with an increase in the V10 index without really much change in systolic function. And as you are increasing or sort of flattening the end diastolic pressure volume relationship, the loop just becomes bigger and becomes wider as the stroke volume increases. And that in turn results in some energetic differences, most notably that the pressure volume area increases from the low speed. We then sort of the second sort of part of the paper was that we looked to see, we sort of did a literature review of all patients who were entered into trials trying to identify predictors of right ventricular failure after LVAD implantation. I think there were 9 studies that we identified. And we sort of created in Dan Burkhoff's Harvey model, sort of this prototypical patient with right ventricular failure after LVAD implantation. And we tried to see if we could, and in Harvey, in Dr. Burkhoff's modeling program, you can specify the amount of interventricular interaction according to the phase of the cardiac cycle, or sort of according to the phase of the cardiac cycle. And we created different models to try to simulate if we could recapitulate what we saw in vivo with these in silico experiments. And these are basically reconstructed pressure volume loops under these different simulations. I've only included these pressure volume loops just so you can visually sort of see the changes in the pressure volume loop when you apply these interactions into the Harvey simulator. Here you can see what the effect is of adding systolic interactions on the pressure volume loop is. Relatively minimal change in LV PV loops. It just unloads the ventricle a little bit. When you apply diastolic interactions, again, not much change in the LV PV loops, but you do see a pretty significant change in RV function. Again, the ED PVR flattens, so the ventricle becomes more compliant. And as a result, you see increases in pressure volume area, and that stroke work, similar to sort of what we observed clinically in that 4th patient, or subject number 4. And then when you sort of combine the two and you incorporate systolic and diastolic interactions into the model, you get sort of this hybrid effect. You see more profound changes on LV function, or I should say on the LV pressure volume loop, and less significant changes on the RV pressure volume loop. And so then what we did is we conducted these sort of simulated or theoretical LVAD ramp tests. So in Harvey, you can actually sort of plug in a LVAD into the patient, and you can change the speed of the LVAD. And so we did that at sort of discrete LVAD speeds, and then look to, and when you do that, the model will sort of spit out hemodynamic parameters like CVP, wedge pressure, cardiac output, and that's what you see graphed here. Again, this is a little bit complicated, but the important thing to note here is that fundamentally, regardless of how you incorporate interventricular interactions into the model, the change in the output parameters, CVP, wedge pressure, cardiac output, is not really fundamentally different when you incorporate these different interactions. And that was also recapitulated when we looked at other sort of geometric outputs like end systolic volume and diastolic volume. You can see in the curve on the right that when diastolic interactions were incorporated into the model, there is certainly an increase in right ventricular and diastolic volume, but the extent to which these small sort of, less than 10 ml increases across a very wide range of LVAD speeds would be clinically meaningful was sort of suspect. And so to sort of wrap things home and just give us a couple minutes to discuss some of these findings, I think what we learned from this study is, number one, that interventricular interactions are heterogeneous, meaning they show up in some patients in one way and in other patients another way. When you see systolic interactions at play, what appears to occur is that systolic function is actually worsened. So as you increase LVAD speed, you see the end systolic pressure volume relationship lose its slope if those systolic interactions are at play. In contrast, diastolic interactions seem to have the opposite effect on RV function. So the ventricle actually becomes more compliant and, at least in theory, would operate more efficiently when they are at play. But again, the balance between these two opposing forces is not clear yet. We need to do these studies in more patients to really understand sort of in which patient they manifest, and understand a little bit more about these phenotypes before we can make any definitive conclusion. The other thing that we also noted sort of in the paper is that, at least based on the in silico modeling, we did not think that systolic or diastolic interactions, even under very extreme conditions, could result in some of the sort of overt right ventricular failure that we observed clinically. And so the sort of conclusion from those in silico models was that perhaps there are other reasons, not interventricular interactions, which result in right ventricular failure post-LVAD implantation. That can at least be said from the models, which only capture acute changes in ventricular hemodynamics. So we can't necessarily speak to some of the more chronic or even subacute adaptations that could occur. So with that, just before we sort of open it up, this was a massive team effort. Each of these studies takes hours to complete. And so we're really grateful to an awesome team here at Columbia, as well as our collaborators at Allegheny General with Manreed Kanwar and Matt Lander. I hope I haven't bored you guys too much. This is what my home life looks like pretty often. But I included my email, and you guys are more than welcome to email or call really whenever. We're always excited to have collaborators and always excited to sort of share our data and see how we can maybe think about it in a new way and leverage some of the the interesting ideas that other people outside of our working group have.
Wonderful, thanks, Mickey. That was really, really interesting work, and it's something that hopefully will have a really good, strong clinical application once you guys pin this down a little bit more. So I'm gonna take the screen. Well, I'm gonna stop the sharing. I'm gonna stop the sharing for now, just so we get everyone back up here. Anybody in the group out there have a thought or a question they'd like to ask Dr. Brener? Well, while we're waiting for anybody to think of anything they might like to ask. So I guess like in the short term now, like based upon the ideas that you've seen, and how pump speed affects right ventricular physiology and hemodynamics, based upon the things that, at a center where you don't have the technology or the skill set that you have at Columbia, but maybe you have right heart cath and you have transesophageal or transthoracic echocardiography as ways that you might be able to assess RV function. Is there any way that you think you might be able to correlate some of the things that you see with that type of diagnostic testing to kind of help determine what might be the most appropriate speed setting?
Yeah, that's a great question. And I think, what we've learned from doing these studies is that they are very cumbersome and they are challenging to do. And so, the idea that they would become sort of prime time for routine clinical use is not going to pan out. So we definitely are looking for non-invasive parameters that can correlate very well with what we're finding from the invasive hemodynamics. I think that there are two sort of strategies that we are exploring to that aim. So the first strategy is actually to recapitulate the pressure volume loops non-invasively. And I'm very excited about that. We actually have collaborated a little bit with some colleagues at Yale, Dr. Hirt, who I think is in cardiac anesthesia, and has spent a career sort of understanding right ventricular mechanics as well, has some really interesting data on this, basically trying to superimpose volume-based data that you would get, let's say, from 3D echo, where you can construct a volume time curve, and then superimposing that with a pressure time curve that you would get, for example, from routine right heart catheterization and like an RV waveform. And I think that's a really promising avenue of research. And in order for that to be sort of realized, we need to get a library of very good quality, invasive right ventricular pressure volume loops using the conductance catheter in order to really establish the grounds for a comparison. But I'm very excited about that, sort of opportunity to try to move away from a conductance catheter based approach to generate pressure volume loops. The other sort of avenue is just to use sort of more routine hemodynamic or echocardiographic parameters. I think there I'm a little bit more pessimistic. I think we've seen from our research already that sort of routinely used parameters to describe right ventricular function do fairly poorly in terms of explaining what we see on the pressure volume loop, which is at least widely considered to be the gold standard method of characterizing right ventricular function. The extent, TAPSE, S prime, even some metrics like strain, I'm really not sure capture the complexity of the physiology. One caveat to that is that I think indices that relate sort of that capture hemodynamics throughout the entire right heart circuit may have more success in describing right ventricular function. By that specifically, I mean right ventricular pulmonary arterial coupling, I think is really interesting, because that not only describes RV function, but it sort of relates that RV contractile function as it relates to the load against which the RV has to pump. And so RV-PA coupling, for example, can better characterize, or risk assess an RV that is, pumping at, let's say, a peak pressure of 25 millimeters of mercury, because the PA pressure has been 65 millimeters of mercury for a long time versus, you know, a pulmonary artery, I'm sorry, versus, you know, an RV that is otherwise healthy and has low, you know, filling pressures. There's, you know, taking that even a step further, there's been some recent research sort of relating the entire axis. So this is like coupling on steroids, but RA to RV to PA coupling, and thinking about sort of how the entire chambers are sort of aligned. And I think those kind of non-invasive descriptors are going to have much more success in describing right ventricular function, especially in these patients with complex physiology, than really anything that we are routinely using, even things like strain.
It sounds like you know, you and your team have a lot of work ahead of you to kind of explore some of these areas. Just as you had mentioned about collaboration, you know, obviously Dr. Burkhoff and Dr. Uriel are pretty well known in this area. Is there anybody else in the country that does this type of work? So I'm just not familiar.
Yeah. So, you know, the extent to which people are actively doing these studies, I'm not 100% sure, but certainly we learned a lot from Bill Cornwell, who's at University of Colorado, who's fantastic. He really sort of helped us get some of our projects up and running. I think his area of expertise is a little more focused on sort of understanding the right heart under sort of normal conditions and in like the athletic heart. And he's done some really interesting work in that field. Also, the group at Hopkins with Steve Sue has done some interesting work in the context of pulmonary arterial hypertension. And I think his mentor, Ryan Tedford, I believe has done some work still at MUSC. Certainly had started at Hopkins, but I believe has carried over to doing additional work at MUSC. And so there definitely are other sites around the country that are doing these sort of studies. And sort of the name of the game, which is what was captured in that review that was just published in CircHF, is that we have to sort of pool our experience together in order to really be able to meaningfully sort of utilize these data. I think you will see pretty soon there's some work in the transplant world, sort of understanding the RV post-transplant out of the Methodist group in Texas. And then internationally, there are two main centers, one in Leipzig in Germany, and the other in Erasmus in Rotterdam, who've really focused on sort of right ventricular function in patients with both HIF-PEF as well as structural heart disease, which is a particular interest for me. And so there definitely are a lot of other centers. If you are interested in sort of starting your own program, what you just need is a lot of patients and a really good echocardiographer. I can sort of get to some of the technical reasons why you need a good echocardiographer, but it's just really important to work well sort of with imaging colleagues when sort of processing the pressure volume data.
Very, very, very cool stuff. Well, I'm going to, I think we're going to go ahead and wrap up. So, Mickey, thank you so much for taking the time, and really appreciated hearing from you. And, you know, hopefully we get to see you again sometime in the future, and keep looking for your papers to be coming out in this this domain.
Great. Thank you, guys. Really appreciate the attention. Thank you.
All right. Bye-bye.
Thanks.
Thank you.